Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by ISAC, the International Academy on the Science and Impact of Cannabis. Visit their website at isac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Prepare for a pre-episode discussion on pre-diseases. I'm your host, Dr. Ronit Lev. What is pre-disease? That's a medical condition caught in its early stages before it gets bad. It is well established that we can prevent bad disease by screening and catching the condition early in its pre-disease stage and applying treatment. Take, for example, cervical cancer. If we screen for cervical cancer with pap smears, we can detect precancerous lesions and treat them before we get full-blown cancer. The same goes for glaucoma. Screening for glaucoma by measuring eye pressure, we can detect pre-glaucoma and treat high eye pressure to prevent full glaucoma and blindness. The same goes for screening for high blood pressure, for hypertension, and checking blood sugar and hemoglobin A1C for diabetes. What about addiction? Is there such a thing as pre-addiction? Can we screen for addiction and detecting pre-addiction in order to make an intervention and prevent full-blown disease and overdose deaths? That is a concept published in JAMA, the Journal of the American Medical Association for Psychiatry, in August 2022 by prominent national addiction leaders, Dr. Thomas McLellan, Dr. George Koop, director of the National Institute on Alcohol Abuse and Alcoholism, and Dr. Nora Wolkoff, the director of the National Institute on Drug Abuse. These three leaders came together and said it's time to start talking about pre-addiction. So we're going to talk about it. And you can hear Dr. Wolkoff's discussion with me on episode number 107. And with that, let's hear our question of the day.
Hello, High Truths. My name is Ray Hanstead, and I'm the Senior Policy Advisor for the Center for Community Research, where we're working to identify and advance prevention-based policy strategies. Thank you, Dr. Lev, for inviting me to submit a question. Mine is, what is pre-addiction, and is it like pre-diabetes? Thank you for clarifying.
Thank you, Ray, for your excellent question. It's definitely a pleasure working with you in the Center of Community Research and helping San Diego County out with the issue of drugs and drug policy. And thank you for framing this excellent question. And we need to go straight to the source to get an answer. We need to go straight to the first author of the publication on pre-addiction with Dr. Tom McLellan. Dr. McLellan has been a career researcher in addiction treatment and policy for over 40 years, working primarily at the University of Pennsylvania and as founder and CEO of the Treatment Research Institute. He has worked at the White House and formulated President Obama's drug control strategy and made sure addiction was included in the Affordable Care Act. He has published hundreds of articles and won many distinguished awards. To learn more about Dr. Tom McLellan, check out the High Truth show notes. Dr. Tom McLellan, welcome to High Truths.
Thank you very much, Ronit.
Well, I'm very excited to have you here, and you bring a lot of perspective. You have 40 years in the addiction field, which brings history. And can you share with us how you came upon the field of addiction medicine? Was there even such a thing 40 years ago, and how things have changed over the years?
Well, first of all, I'm it's closer to 50 years, actually. And I came upon the addiction field very much the way many people do. I stumbled upon it. I had gotten out of graduate school. I'd had some money. I bought a farm. I drew a circle around that farm of 20 miles. I looked for a potential employer. And the one that came to mind was the Veterans Administration Medical Center in Coatesville, PA, where they were just starting what was called a substance abuse treatment unit. Nobody knew what it was. It was designed to do something for the basically an epidemic of returning veterans who were addicted, and it was politically impossible to incarcerate them. So they thought, let's try treatment. But it was just starting, and I knew less than the people who were there. But I loved it. I loved it from the very beginning.
Very cool. And of course, there's no shortage of issues of drugs and addiction over the years. But what have you seen kind of change in attitudes and drugs? It seems like they're just stronger over the years.
Yeah. I just heard today that the opioid addiction was the epidemic, more opioid addiction than ever before. I'm not sure that's true. My research tells me the worst opioid epidemic was right after the Civil War, when there were so many patent opioid medications and so many people were addicted. Nonetheless, you're quite right. There's no shortage of substances to be addicted to. These frightening things are. I know that, not that long ago, there was efforts to get marijuana legalized. Now, in the cannabis field, it's not marijuana anymore. It's synthetic cannabinoids that are produced in laboratories. In the opioid field, it's fentanyl, synthetic opioid. On the public side, I am hopeful that we are finally beginning to see this as a public health and clinical health issue rather than a legal problem. That's a new thing. And the problem is, as far as I'm concerned, the problem is that the addiction treatment system in this country was constructed when we still thought of addiction as essentially a character disorder or a personality disorder. And the idea was you would put the addicted individual someplace where they would, have an epiphany. They would, go back and reconstruct their personalities and learn honesty and responsibility and all that. Now, I'm not arguing against responsibility and honesty, but that we now know is not the essence of addiction. The essence of addiction is loss of control, which seems to be mediated with a genetic predisposition, and is now mediated by use-related changes to inhibitory, reward, stress, motivational circuitry in the brain. The problem is the treatment system that was constructed was specifically created outside the healthcare system and the medical system. So to this day, there's less than 30% of medical schools or nursing schools even have a single course in addiction. And so that transition from something that was a problem of bad parenting, poor character, poor morality, into a chronic illness perspective has been very, very difficult to bring about. But it's necessary.
And I think what happened, the silver lining in all of this, I see, is when the medical community became the drug dealers by prescribing opioids, and I'm one of them, we came to be part of the solution as well.
Well,
So,
boy, I hope that's true. And you're right. That is one of the silver linings. Um, I know that at the University of Pennsylvania, in the medical school, until very recently, it was taught that drugs are not the problem. It's the person that gets the drug that's the problem. So it was not. It was thought that if you gave pain medication, you could give it for any period of time, as long as the person didn't have an addictive personality or proclivity. And that is just flat wrong. So that was taught to doctors for most of my career.
yeah.
Now they know better. Now they know that protracted use of an opioid, even for pain, can produce problems.
Yeah, that started at the beginning of my career. That's exactly what I was taught, but it never did make sense. But I followed the rules because that's what a young doctor does. And now we're making up for that mistake.
Yeah. And but still, even last year, I think it was over 100 million people got a legitimate prescription for an opioid for pain relief. I'm not saying that that's inappropriate. I'm just saying that there's going to be that tension about the appropriate but restricted use of an opioid for pain or analgesia, and the side effects associated with protracted opioid use.
And not just opioids, right? Benzodiazepines and stimulants and all those drugs. So that's why we really teach and promote safe prescribing.
My colleague, George Woody, was the first person, to my knowledge, to submit a paper discussing the potential addictive properties of benzodiazepines, at that time Valium. The reviews and the public, the professional outcry was overwhelming. They simply wouldn't believe it.
Yeah.
3 decades later, you're exactly right.
Yeah.
All these drugs have very legitimate, very important medical uses. So you're not hearing me say we don't need opioids, we don't need benzodiazepines, we don't need stimulants. But I think doctors have begun to be aware that all these drugs have side effects.
Right, especially when used in combination with each other.
Oh, yes.
So, Tom, I reached out when I read a paper you authored in JAMA about pre-addiction, and I was like, "Ooh, that's interesting. What is that?" And that's the question that we have for you today. What is pre-addiction, and is it like checking for pre-diabetes?
Well, it is a concept. It is not a finished product. It is not a set of findings. It is a concept. And it derives exactly from prediabetes. That's where I got the idea. And before I go further, I want to be clear. I am not arguing that we need pre-addiction because addiction is so like diabetes. Huge differences between addiction and diabetes, between addiction and cancer. But for both those illnesses and many other, particularly chronic illnesses, the problems that chronic illnesses like addiction face are these. One, often people do not enter care at all. The penetration rate is low. Two, if they enter care, it is very late in the stage of the illness, and consequently you have comorbidities, physical medicine problems, but also other problems. Often for the people who are in late stage on their illness, prognosis is poor, adherence is poor, outcomes are poor. Now, all of those things are true today for addiction. People don't want to go into treatment. They resist it when they're in it, and the outcomes are not as good as they ought to be. But in the diabetes field, faced with the same problems, they came up with a concept and later a health strategy. And it was interesting to me that the creators of the term prediabetes were not administrators, not public health officials, not clinicians, not researchers. It was the American Diabetes Association. This was the advocacy group for those affected, the individuals, but also their families, by diabetes. They said, look, if we have all these problems, but we are able to predict who is likely to go on and become a full-blown, have a full-blown case of type 2 diabetes, why are we waiting for them to do that? Why don't we intervene earlier? Why don't we create the concept called pre-diabetes? And it was a concept that was, the word was created because it had a broad inherent understanding, not just among clinicians, but the public at large. Everybody knew what diabetes was. But more importantly, it had motivational significance. If I told you you were about to get a thing that you didn't want to get, you might want to take some action, and clinicians might want to take some action. And so that's where it derived. Now, interesting things to me, people say, oh, this is never going to work in the addiction field. First of all, we understand diabetes and its characterization very well. We know the metabolic pathways. We know the all the effects of it. Two, we have proven medications and interventions that were designed to treat pre-diabetes. Three, pre-diabetes, we have the moral and clinical authority to do something about pre-diabetes because that condition itself is has public health and clinical health significance. And we have laboratory tests that clearly define it. Now, all of that is true. And none of that is true in the addiction field. But that's not really the point. The point is that none of all those very good things that happened in the diabetes field happened after the creation and popularization of the concept. Indeed, it was the American Diabetes Association that fostered participation by insurers who very rapidly found it in their interest to authorize and reimburse even good ideas and early interventions. You could avoid the costs of true diabetes. It would be terrific. There's still not consensus about what is the definition, the laboratory definition of prediabetes. It's still not 100%. There's still not 100% ability to predict, even for those who show early signs, whether they're going to go on. But none of that has mattered. What's mattered is that it has started a strategy of moving interventions earlier on when the likelihood of having something effective is increased, and the nature of the intervention is changed as well. The interventions are, by design, more easily able to fit into a patient's daily repertoire, more attractive, easier to do. And it's that general concept that we are suggesting, doctors Nora Volkoff and George Koob and I are suggesting that those ideas are certainly true today for addiction. And some of the strategies that the diabetes and cancer and more recently hypertension fields have done why don't we try some adaptations of those in the addiction field? Sorry for the long answer there, but
No, that's great. So I could just picture this room. I mean, you're talking about three giants, like you mentioned, Dr. George Koop, Dr. Nora Wolkoff, and you. Are you like sitting coffee and saying, hey, what can we do to do things earlier? And you came up with this concept?
Just about. Absolutely. Yeah. And I prefer to think of my colleagues as promising young investigators.
Yeah, so that's interesting. And then again, Dr. Wolkoff has that on her blog to really start thinking about pre-addiction. Yeah. It is so, I of course agree with the concept of intervening early before a disease, blows up. But as you mentioned, for addiction, it's a little different. What is the definition of pre-addiction? And from what I read in your article and for Dr. Wolkoff, it's mild or moderate substance use disorder. So it'd be really rebranding the DSM-5 criteria. The DSM-5 criteria has 11 criteria. And if you have 2 to 3 criteria, you have mild disease. If you have 4 to 5, you have moderate disease. If you have 6 or more, you have severe disease, which equals addiction. But so you want between 2 and if you have 2 or 5 of these things, you consider to have pre-addiction, and that's the definition, right?
That is our suggested starting point. And the reason is, first of all, what we don't have. We do not have a laboratory test at this moment that is definitive. It's got high specificity, high sensitivity, and great prediction ability. We don't have that. But it is possible to predict who's likely to transition from use to misuse to addiction. And we think the 2 to 5 criteria, exactly what you said, is not a bad starting point to begin to ask the question. Those criteria are well known. They're easy to apply in lots of settings, clinical and non-clinical settings. And we hope that much more definitive laboratory or other behavioral indicators are going to come along to be even more specific and sensitive.
Well, that's fascinating. Do you see something? I mean, you're right. I find that complicated as an emergency physician. And there's only so much screening we could do. Are you suicidal? Right. Do you have domestic violence? We do a lot of screening. Right. So it kind of gets overwhelming to ask all these 11 criteria in a primary care setting. I think is complicated. I don't think it's simple. And you're right. It's very different than checking a blood pressure, hemoglobin A1C, or your eye pressure, or even a pap smear. Those are very easy, simple stools. So tell me, you must have some ideas of how to make that easier. Yeah.
Actually, I think you've raised a very important general question. Let's suppose we had a definitive, and we don't have definitive measures of pre-addiction. But
we have it kind of for alcohol.
Yes.
The NIAAA has done a really wonderful job of making a definition. Yes. And I could tell, my young children, if you have more than 4 drinks, you're an at-risk drinker.
That's right. And there are suggestive measures for alcohol: CDT, ETG, GGT, MCV are all alone or in combination. Alone or in combination. It's not unreasonable to me to think that there might be a set of laboratory tests for alcohol that would do for alcoholism what fasting glucose and glucose sensitivity tests are doing in the diabetes field. But you raise another important point. Let's suppose I had the test and I could definitively identify and predict the course for addiction. Is this something that can fit into contemporary primary care? The problem is everybody wants their illness to be identified early and treated effectively by primary care. And with no disrespect to my many friends in primary care, a 12-minute appointment, extraordinary time constraints, not very good education, especially about addiction in medical residency training. I'm questioning already whether the early interventions ought to be cited in primary care or they ought to be in a different venue. Well, like what? I don't know, but maybe school health, maybe employment health, maybe non-health settings. But we're not even there yet, I have to admit. I do think 2 to 5 criteria, meeting 2 to 5 criteria is not a bad starting point. And one of the reasons I say that is because I think I recognize the time constraints in primary care and emergency medicine, but it's not terribly difficult to get those questions asked. So I don't think that's the big thing. Another issue is, do you have the moral right? Do you have the clinical authorization to start probing around on this condition called pre-addiction? You do in diabetes because pre-diabetes itself is a significant medical problem. If you could reduce the problems with sugar metabolism there, you have justification. But isn't it possible that probing about for pre-addiction might be further stigmatizing? Might it not?
I don't know. We do that for alcohol and tobacco. It's part of our routine social history. Well, how many packs a day, how many pack your history you have. And that's a risk factor for, tobacco and lung disease. And we have it, but we don't do it enough for alcohol. Like, how much do you drink? How many drinks a week? And well, just so you know that, at your age, and the medications you're taking, you're considered an at-risk drinker. And that affects people. Just saying that, well, that means that you meet the definition of at-risk drinker. If I was able to say something and saying, well, you have pre-addiction, just so you know. And I think that makes people think.
Right. Well, I saw what you did when you said the term. It jolted you. And that's exactly why we like the term. Mm-hmm. If one of the many criticisms of our article was the word addiction is stigmatized. We shouldn't even use that word. And we don't agree with that. Okay. The word addict is stigmatized, just as diabetic, schizophrenic are all stigmatized. But addiction, everybody knows what it is, A, and B, they know they don't want to get it. And that's the point. When you say something that is a signal for something that might reasonably happen to you and that it's bad, we believe that's at least the formula necessary, part of the formula necessary to energize clinical people, but also the patients themselves.
And when you say we, you mean the
three authors. Yeah. These two promising young investigators and I. Yeah. And by the way, I want to add one more thing. You might say, for God's sake, what are you trying to do? Are you trying to reduce partying out there? People drink sometimes, they drink too much. Okay, maybe they smoke marijuana. But is there any reason to believe that any of that subdiagnostic use is problematic? And the answer to that is, this is not an opinion. There's no doubt about it. Misuse, that is, use of alcohol or any other drug at a level that is harmful to you or to those around you, is associated with rape and interpersonal violence among young people, school dropout, accidents and injuries, disabilities and deaths. And so we think the efforts to intervene at the pre-diagnostic level, pre-addiction, has very sound public health justification.
Right. So it makes sense. Usually people who have a substance use disorder wait till they hit rock bottom before seeking help. And at that point, the disease is harder to treat. It'd be like waiting for you to have metastatic cancer.
Exactly.
That was resistant to treatment, and now we're going to try to do something. And then, then we're offering palliative care, which is more like harm reduction instead of intervening early. So is there science behind the concept for addiction like there is for cancer, that if we treat it early, you're going to have better results?
The answer is there's suggestive evidence. That's the best I could possibly say. Mm-hmm. And I remind you that most of the, quote, evidence, most of the interventions, most of the medications for pre-diabetes occurred after the concept was put into public view. But I think there are potentially some important things that could be done and built upon. But clearly, much more research is needed. Screening and brief intervention, that's already reimbursed. It's been used. It's met nobody's idea of what it could reasonably do. Very difficult to do in primary care settings. But when implemented, it reduces drinking in the target group and has been shown over and over to be effective. Medications that have had modest effects in serious alcohol and opioid using patients might have much more significant effect if used earlier. Mm-hmm. But yes, you have to be careful. There are side effects with every medication. So this all needs to be researched. But that's what we're calling for, is to begin to look a little bit earlier into the trajectory of substance use and try things and develop new things. A whole genre of things that's already out there are these internet and app-based applications that are community support efforts to reduce things like bullying, anxiety, eating disorders, healthy living. Noom and many other of these organizations are making a living by identifying social behavioral problems early and giving practical advice and community support to behavioral change. Could these be brought to bear in the alcohol and other substance use area? I don't know, but I think the question is worth asking.
Interesting. So I read the comment sections, at the bottom of the article. That's, you have your basic article and what everybody's saying on it. One of the comments came from a Dr. Weiss, and I'm going to paraphrase her, but she said pre-diabetes started when the drug companies were focused on reducing hemoglobin A1C. So there was a target, the hemoglobin A1C, and big pharma had an interest in educating people because it would increase their profit margin. And she argues that, substance use disorder doesn't have a specific drug or big pharma to intervene at that level. So it may not be as easy. Do you think that that's true? Do we really need big pharma to make this happen?
Well,
I mean, I don't think so, because I'm using tobacco and alcohol as an example.
Yeah. Factually, that simply isn't true in the case of diabetes. There were no approved indications for any of those drugs until diabetes had reached a certain level. It was the introduction of the concept, the research that followed it, and very importantly, the insurer's willingness to reimburse that did certainly, as she points out, open the door for earlier use and develop of different kinds of medications that were more appropriate to early stage. I know that naltrexone for alcohol addiction has significant, but I have to say modest effects for the very mostly severe. Also, it seems to work better for alcohol-dependent individuals with a very significant family genetic history for alcohol use disorder. Okay, but couldn't that same medication for the same group of people applied earlier have even more positive effects? I don't know the answer, but that's why they do research.
Interesting. All right.
But back to the essence of what her comment is. And I'm sorry, I don't know her. I'm sure she's a fine physician, but the thinking is backwards. And we got that when our paper was reviewed by lots of very prominent reviewers. They all thought that the concept followed the development of the screening test or the medication or the intervention. That is just factually not true. All of that resulted from the concept, followed by political and insurance advocacy. And that's what resulted. The NIH got lots of money to develop and test new interventions once the public outcry led to it.
I think it'd be a lot easier to screen if you honed it down, like maybe for a few questions, like the cage questions or something like that. That would be equivalent to your mild to moderate DSM-5. Because right now, I think it's hard to do. But if you were able to simplify it, no more than 3 questions.
So, or even easier would be if it were self-administered on a computer or on a phone app with the result given to the physician or the nurse, whatever. Even easier would be a litmus test. Even easier would be a urine test. Well, that may happen. But again, the essence of what Drs. Volkoff and Koob and I are saying is that first you need the concept, and first you gotta wanna intervene earlier, and research and development follows that.
You know what? I bet you just gave me an idea. There's a lot of employment drug screens that occur, and these are open book tests. And so one of the deans at a medical school in New York said that their medical residents who are new to the job were failing their open book drug screens. And they would tell them, okay, in 3 months, we're going to do this again on Tuesday. And they'd fail it again. I think that's a pretty good screening for having at least mild to moderate substance use disorder if you can't pass your open book drug test with 3 months in advance to study for the exam.
Oh, there's so many examples of that. I used to consult for the National Football League. Multi-$100,000 bonuses were contingent upon passing your drug test the day you sign up at the combine. And as many as 25% of these recruits were losing $100,000 because they had marijuana in their urine. And, some people call it an open book test. Some people call it an IQ test. But either way, it's indicative that somebody either doesn't know enough or can't control enough to not have a positive test.
And the answer that this medical school did to solve their problem of doctors failing their drug screens is to get rid of the drug screen instead of
of course, perfect, great,
right. And that made me sad. How would you like your surgeon to have a incoming, knowingly that they have such a problem, instead of doing what you're doing, saying, okay, well, we're worried that you have pre-addiction, let's treat it.
Interesting you bring up physicians. One of the most compelling evaluations I ever did, I did with Dr. Greg Skipper and Bob DuPont, of physicians who were addicted. There are programs, every state, I think, except perhaps one, has physician health plans for people whose colleagues identify them as potentially having an addiction problem. And the the physician is offered, first they're asked to undergo screening, and if positive, and screening is laboratory tests, but also a rather significant interview with them and the families. But where it's positive, they could lose their license. But more often, they sign up for traditional treatment that is followed by 4 more years of monitoring and a lot of support. Well, I didn't believe it when we started, but we evaluated 1,000 people for 7 years. That 1,000 physicians that were identified, followed them with greater than 85% total success. And you take any measure you want: employment, substance use, harm to self or other, anything. Family. 85% success. And you might say, well, of course, they're physicians. My God, they've got all kinds of public support. They got a lot to lose, everything else. Well, physicians who went to the same programs and just got what, quote, normal people get, 30 to 60 days of residential care, they had 50% relapse rates within 6 months, just like everybody else. The reason I bring it up is, suppose I told back to diabetes. Suppose I told you, there's really effective diabetes treatment. You can get 85% improvement rates. Oh, sorry. You have to be either an airline pilot or a physician to get it. The American public wouldn't put up with that. Yeah. There are effective ways of treating addiction, and I think there soon will be effective ways of preventing and intervening early. But first, the public's got to demand it.
Yeah, interesting. So let's change gears a little bit. I want to ask you about drugs in general, because you've written our nation's drug control strategy under Obama and have seen it changed over the years. What's your perspective on that?
I am very sad at the state of political discourse and legislative action in the addiction field. And I was upset about it in the last administration, and I'm upset about it in this administration. And I don't understand it. I hear that addiction, drug use and alcohol use, is one of the few issues where the parties seem to agree. I know from serving on the Surgeon General's report, I know from helping with the Christie Commission report, I know from reading the National Academy of Science that there are many practical, sensible legislative things that could markedly change the attractiveness, the implementation, and the effectiveness of addiction care in this country. And yet nothing's been done.
What would you like to see? What would you like to see happened?
All right, I'll give you a short list. First, the waiver. There's a proposal now to drop the waiver for physicians. The X waiver to prescribe one of the medications that's useful in opioid addiction. Mm-hmm. I think that's stupid. With less than 30% of medical schools.
Wait, you're against removing the X waiver?
I am. I'm against dropping it. What I suggest instead is that this is an opportunity to provide some education to a prescriber workforce that hasn't had that education in their medical and nursing school training. So my suggestion would be, as part of the DEA certification to prescribe opioids, you also get the waiver, the same 8 hours of instruction on what you do if your prescribing of opioids turns into an addiction. I do not think that's too much to ask of budding physicians and nurse practitioners.
I think
it would be effective.
I lived through that. And so, Tom, I hear what you're saying. You're coming from it from a good place. Let's educate people.
Yeah.
But having been on the receiving end of government mandate education, I received, 12 hours of mandated pain education. By the time you mandate it, it's already expired, outdated. I took that pain education, and that made me prescribe more and hurt people. And then I took the 8 hours of X waiver education. I came out of that with more questions than answers. And government mandated education is not the right way of teaching a medical community. We've learned how to treat COVID on the fly and in a good way, in a systematic way. I've learned how to do dangerous things, right? Central lines and ultrasound exam, really complicated things I've learned after my training. We have a good way of medical education, but government mandates on your license has, in my 30 plus years, the receiving end has proven to be bad with unintended consequences.
That's probably one we'll disagree on. Okay. Here's another. You brought up COVID. At the start of COVID, there were no medications to treat COVID. There was no vaccine, right? But there was clear indication it was a medical problem. What did the government do? Republican administration then, and followed by the the Democrats. They produced Operation Warp Speed. They incentivized business to rapidly discover and develop and broadly implement not rapidly enough, but very rapidly in terms of history, very rapidly developed effective vaccines and got them out to the public.
Yeah.
Similar work was done with AIDS. Remember, AIDS was extremely
great job.
Stigmatized. They wasn't sure what it was. I lived in the era where physicians would not touch an AIDS patient. Very rapidly, with advocacy from primarily gay and other affected people, business, government worked together to develop. Now AIDS is no longer a life-threatening illness. It's a chronic illness.
Too.
Yeah. Where's that for addiction?
I agree with you. I agree with you with that. Absolutely agree with you. But making you take some government mandated course is not gonna. That was never done with AIDS or COVID.
I'm off of that one. We'll agree to disagree with that. But here's another thing.
Okay.
A tremendous amount of money has been spent. State opioid responses. Lots of dollars have gone into the opioid issue. But where did those dollars go? And then the opioid settlement grants. Where did those dollars go? The great majority of those dollars have gone into the same antiquated treatment system that supports about 16,000 public addiction treatment programs. Now, God bless those treatment programs, filled with well-intentioned, earnest people trying to help. They cannot, I don't say this with any pleasure at all. Those programs cannot deliver comprehensive, effective care. They just don't have the resources. And they don't have this infrastructure. They're not part of the medical establishment. They are purposely segregated with their own sets of money. And the primary ingredient after 50 years is group counseling. Group counseling is not a bad thing. I have participated in it. I've seen people do well in it. It's not enough. A comprehensive, coordinated, continuing care program involving medications, professional therapies, support services is possible, but not in that antiquated infrastructure. That could be changed. One way to do it without putting all those programs out of business is create a tiered licensing system where those treatment programs are, let's call them tier one, and they get support for providing group counseling. A tier two program would get far better funding contingent on the capacity to deliver high quality, comprehensive care and be associated with a medical establishment, a healthcare provider. So many of the addiction treatment programs have no contact at all with the rest of medicine. So their PTSD, their depression, their chronic pain, their diabetes, their hepatitis, it cannot be addressed in that context. Mm-hmm. There are plenty more of these. So call me very disappointed in government action.
Yeah, I agree with you. I see billions of dollars going at a problem and not fixing it, and that sometimes good money after bad, right? Like
I agree with that.
I don't see that making a difference. It's like, oh yeah, I'm spending so much money, but what results are you getting, right?
Right.
Okay, so we'll agree there.
Yeah, we'll agree there. Sure. There are plenty. And by the way, there are good organizations that the Legal Action Center, Partnership for Drug-Free Kids, the group project from Harvard School of Public Health. They've all listed government actions that are possible now that will not only not cost much, they will reduce costs.
And you're talking about primary prevention.
No, I'm talking about, to some extent, prevention, but also existing treatment. In fact, the majority of it is, most of the recommendations are for treatment. Treatment's still being done in an antiquated way under an outdated view of what addiction is. If we treated, I don't know, diabetes the way it used to be thought of, we'd be in the same boat.
Yeah. What do you think about, you mentioned our political divide and the divide in solution that we have on solutions for addiction. What about the whole movement to commercialize drugs? And I think you alluded to that when you said, well, some people say, oh, you shouldn't call addiction. People don't have addiction. Well, no, that's something we try to prevent. That's not a bad thing. And I'm thinking that a group who wouldn't like to have it called addiction, well, it's like I can have a cocktail. I can also have a line of cocaine. Not everybody has a problem with that. And there's a huge movement to commercialize and normalize drug use, starting with all the marijuana products and psychedelics and more. What do you think of that?
So I have a view. It's my own. We'll see what you think. In my mind, it was a terrible idea to, quote, legalize medical marijuana or recreational marijuana. It was done at a time when we had a lot of unemployment in the country. We're coming off a terrible recession. And there were two major driving forces. One was there had been a tremendous amount of arrests and incarcerations of particularly young African-American males whose major, quote, crime was smoking marijuana. And that was thought to be a terrible waste of money, of incarceration and stigmatization for the rest of their lives. But I certainly agree with that. And two, if we legalize marijuana, it will produce opportunity for local companies to get in and it'll create jobs and new wealth. So I think those are reasonable reasons to legalize, but I think they took the wrong path. I think the right path would have been decriminalization, which is completely different. Decriminalization is when you reduce the penalties for a crime, a problem, to more appropriately suit the nature of the crime. Like they don't put people in jail for parking tickets or speeding tickets; they give them tickets. That's the right, as far as I'm concerned. That's what should have happened with marijuana. When you legalize, you're sanctioning. You're saying, "Oh, it's okay to smoke. It's okay to use this. Use it responsibly." All that, and I don't think that's true. I think the health problems. People always say the marijuana is just about as harmful as alcohol, and I agree with that. Well, alcohol is very harmful, harmful use, all that. When used responsibly, of course it's not. But there are problems associated with that, and there have been clear problems associated with the increasing use of marijuana. The literature is replete with it. At a time when American educational systems are going, we're falling behind India and China and everything. Our kids don't graduate from high school. They don't know how to do math. They can't read. Oh, I know. Marijuana legalization will be a good idea. I'm not buying it.
So I agree with you. The way they won the war is by mixing the issues of criminalization and legalization, getting people mixed up with that. To this day, people don't know how to separate those two. And that's kind of why that's happened. I live in California, so I just got to live with the facts. So I can't be against legalization. That's what people voted for. I don't think they voted for the consequences, because what's happened is since, Prop 64 passed, you're not buying marijuana now. You're buying meth. 98% THC is more like meth. And every day as an emergency physician, I see marijuana poisonings, and the health consequences have gone unregulated. And so I see that's the biggest problem, is the commercialization of it, and lack of regulation, lack of protecting our children, our babies. The number one poisoning in little kids under 5 is marijuana. I didn't know that. Yeah. Go to any emergency department around the country, little babies, number one. And I think if you look at big studies where we have a mental health crisis, it's not all because of marijuana, but it's a risk factor. Just like tobacco is a risk factor for heart disease. Marijuana is a risk factor for schizophrenia. So not everybody who uses marijuana is going to get schizophrenia, but do you want that? That's kind of like the pre-addiction, right?
That's right.
Model of prevention.
I see it as a math problem.
Right.
Exactly. I don't care what commodity you're talking about, Hershey bars, iPhones, whatever. Efforts to make that commodity easier to get, cheaper, more accessible, you're going to have more users of that commodity. But in the case of substances with an addictive potential, about 25 or 30% are going to develop a problem, some kind of a problem, an automobile accident, problems at school or concentration. And about 10% are going to develop full-blown addiction. These are approximate numbers, but they're not way off. So efforts to increase the use are going to have mathematically predictable results at the severe end. And it's not all addiction. It's misuse as well as addiction.
Right. Very sadly. And I talk to mothers whose children have addiction or committed suicide from cannabis-induced psychosis, and they had no idea. So the reason marijuana is different than alcohol or opioids or cocaine or psychedelics is people who use those other drugs. People, if you're using methamphetamine, you kind of know it's not good for you. You shouldn't be doing it, but you have a problem. People who use marijuana think, oh no, I use it as much as I can. It's good for me. And they think it's helping them, and they're being tricked and lied to. It
makes me relax while I'm driving is what I hear all the time.
Yeah.
That sends shivers down my spine. Yeah.
Right. That's very scary. And we've done simulation tests behind the wheel. People are impaired, but they don't know they're impaired.
They're not aware. That's exactly right. Yeah.
So that's
there you go.
That's why I think that marijuana is a little different. What about this whole harm reduction? This is the first year that the National Drug Control Policy included harm reduction. People define it the way they want to define it. What are your perspectives?
Yeah, well, once again, you're pressing one of my special little buttons.
Oh, I think I'm getting good at that.
First of all, I mean, who is for harm production? Do you know anybody who is arguing for harm production? I don't. You pinpointed something that's problematic for me. Everything in some of these formulations, methadone, buprenorphine, these are harm reduction strategies. Maybe, but I call them medications. That's what I would call them. In my mind, I'm for any initiative, effort, intervention that reduces the likelihood of problems. Okay, but I'm not for anything that increases the likelihood, frequency, duration, intensity of substance use, because substance use is problematic. So early intervention, screening, brief intervention, medications, all that I'm for. Supervised addiction, supervised injection sites, no, sorry, I'm off the train there. I've seen all the research. It may not be very effective, but at least it's expensive, extraordinarily expensive to implement.
Right, and I think that people don't understand the addiction. My own colleagues, my own addiction specialist colleagues in emergency medicine, I think I was the only one in the room to explain the difference between needle exchange, which is evidence-based, preventing hepatitis and HIV, versus safe injection sites where that's bricks and mortars and somebody watching you overdose and giving you naloxone. It's very different concepts that, just like you said, costs a lot of money. And here I am sitting in the emergency department where I have patients who are crying, begging me to send them someplace for their addiction, and I have no place to send them to. Right. So how are we investing in people who are using? You could use anywhere you want, but there's not enough places for people to get help when they want help. I have no place to send them. So where are our priorities?
I'm sorry, but you're not going to get any argument from me on that one. That is, I think that's a clear one for me. Yeah.
So I kind of use the opioid prescription model of what happened. You said that you were on the Christie Commission. I think we tackled that problem. We no longer have an opioid prescription epidemic that we did. And that's what got me into this field when I, as a physician, was harming the public when, I made a vow for my career to do the exact opposite. And that got me engaged. And I think we tackled that problem on the supply side, right? We're no longer over-prescribing. We may not be perfect, but we're not over-prescribing like we used to do. And there were patients who would come into the emergency department, they would be on a bucket of medications, and I'm like, what am I going to do with this? I just need to keep you alive somehow. I'm not going to take away your bucket. I'm going to just keep you alive somehow. But I'm going to end the problem by preventing the next generation of Americans who won't be addicted to opioid prescriptions anymore. And we did it. We did it in a fairly short period of time, 20 years, getting into the problem, getting out of the problem. So I am a big believer on primary prevention and reducing supply as a good, if you had, it's all important, like you mentioned, but if I wanted to really make a big ding in things and save a generation, that's where I would put some emphasis. I don't know if we're doing enough of that.
I think the trajectory of opioid prescribing, I know it's a fact, the trajectory of opioid prescribing has changed, and I agree with you there. I wouldn't exactly proclaim victory at this point. 100 million people got an opioid prescription last year alone. And I don't agree that we've developed the right procedures for getting people off or transitioning them off. But you're completely right that there's been big progress. And to me, what that suggests, my whole theme of my the last years of my career has been that substance misuse and addiction has to become much more firmly part of the rest of healthcare and medicine, because when medicine decides to change, they do a damn good job, and they do it pretty quickly. AIDS, COVID, opioid prescribing, lots of others. But this has been purposely segregated from the rest of medicine. And I think that's been a terrible mistake.
I agree with you. Your privacy shouldn't kill you, right? We should be working together. Right. That's great. Right. So, Dr. Right. McLellan, hopes for 2023.
Yeah. I hope that there will be more broad recognition that the old ways are not the best ways. I'm so interested in the expenditures of the state opioid response dollars and the opioid settlement dollars. I don't want to see them go to the same old tired, earnest, well-intentioned, but simply not effective solutions. That's hope number one. Two, I'd like to see 50% of U.S. medical and nursing schools have at least a one-semester course in addiction. I think it's warranted. The events of the last several years and every minute of every day warranted. And I think it's possible. I'd like to see the Office of National Drug Control in the next administration, whoever it is, I'd like to see it be a cabinet position, not an office that nobody knows what they do. I would like to see something we haven't talked about, which is community-based prevention. I am a treatment guy. I'm not a prevention guy, but I've read the prevention literature, and it's compelling to me. When it's delivered generically and consistently and continuously throughout the at-risk years, that is basically age 12 to age 25, prevention is so effective. It's reduced problems of all types by as much as 30-40%. The prevention researchers at the University of Washington have shown this over and over and over. Penn State University has shown it over and over, but it's never implemented. There's a sign on the road that says, turn here for your hospital. There ain't no sign for, here's your prevention. That could happen, and it could dramatically improve not just addiction, mental health, bullying, early pregnancy, all these things. They all have the same predictive factors, and they just, there's a period in the 8th grade when somebody says, we're going to do the drugs are bad talk now, and it's ineffective. Okay, so those are my hopes for the.
Well, those are great hopes. Those are great hopes.
Okay.
And may like 50% of them come true in the next year. So, Dr. Tom McLellan, thank you so much. It's really an honor to chat with you and to share your perspectives with this high truth audience. And I'm definitely on board. Early intervention and prevention beats waiting for full-blown disease when people hit rock bottom. And I wish you a happy and healthy new year.
And back to you as well. And thanks so much for having me. I hope some of this has been helpful and useful.
And with that, I want to say thank you to Ray Hanstead, who asked a great question about pre-addiction as a concept. She is interested, and especially in doing drug policy. It's a pleasure, Ray, to work with you with the Center Community Research. We do such good work with a lot of passion on behalf of the people for San Diego and on the whole issue of addiction. So I really thank you for that. And thank you, Dr. Tom McLellan. It's really an honor to chat with you, hear your perspectives, share them with our High Truth audience. And I'm definitely on board that early intervention and prevention beats waiting for full-blown disease and tragedy. And I wish you a very happy and healthy new year. Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to ISAC, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isac1.org, that's IASIC1.org, to view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more High Truths.